respected chairperson, senior members of the faculty, and friends. Antithrombotic therapy in coronary artery disease is a controversial topic right now. What is this antithrombotic therapy? It involves antiplatelet therapy along with anticoagulants. As all of us know, we have aspirin, the P2Y12 inhibitors, and the glycoprotein 2B3 receptor blockers on one side, with anticoagulants, which involve heparin, low molecular weight heparin, the vitamin K antagonists, and the novel oral anticoagulants, especially rivaroxaban. So it is this combination that is called as antithrombotic therapy. If you take the risk of a patient for thrombosis, it is much higher in the first month after an ACS event. And as you can see, that blue line coming down over 30 days, the bleeding risk is remaining the same. So our main problem is to prevent a thrombosis in the initial part and to reduce the bleeding risk as time goes on. But if you take a chronic stable patient, he is also not very stable, as is shown on that graph. After the first event, after some time he gets a second event. So can we scale down the antithrombotic therapy as time goes on to reduce the bleeding? That is the main point of discussion now. Well, in any case of acute coronary syndrome, we all know that we use a dual antiplatelet therapy, what is called as DAPT, which involves aspirin plus one of the P2Y12 inhibitors, along with parenteral anticoagulants, heparin or enoxaparin. The rationale for using two antiplatelet drugs is that platelet adhesion and aggregation are the early steps in the formation of an occlusive coronary thrombus, and DAPT can prevent this as well as stent thrombosis if you are doing an intervention. The earliest trial that gave the data was the CURE trial, where clopidogrel was added to aspirin, and people found that the primary outcome was significantly lower. See, after the CURE trial, which is one of the early landmark trials, so many trials have come in this field of dual antiplatelet therapy with so many results. There is no controversy regarding this. In the initial phase, one of the antiplatelets should be aspirin. We should use it as a loading dose of 300 milligram, non-entry coated, chewed or crushed for a rapid effect, and continue with a maintenance dose of 75 to 100 milligram. I would like to stress this, a low maintenance dose is equally good. It reduces the GI bleeding, and with ticagrelol, it is recommended that the daily dose should not exceed 100 milligram. Very often we find prescriptions of 150 milligram of aspirin with ticagrelol. It is not to be given. Only a low dose aspirin should be given. The second drug in the dual antiplatelet therapy is a P2Y12 inhibitor. When should we start it and which one? If you look at the 2020 European guidelines on the management of acute coronary syndromes, you find that a pre-treatment with a P2Y12 inhibitor, if you are going to take up this patient for an angiogram and intervention early, is not recommended. It's a class 3 indication. Even though most of us routinely load patients with the P2Y12 inhibitor right from the casualty. Routine treatment with glycoprotein 2B3 receptors again is not indicated. And prasugrel, which is a drug which we use less often, to be considered in preference to ticagrelol in patients proceeding to PCI. I've taken only the controversial statement from the ESC. The rest of us, all of us know. So what is this pre-treatment? Pre-treatment means you give a P2Y12 inhibitor before coronary angiography, before knowing the coronary anatomy. It's often not needed as per many studies because there is lack of any ischemic benefit and a substantially higher bleeding risk. The supportive evidence comes from various trials and registry data, the ACCOST, Dubious, ICER React 5, and the SCAR. ESC strongly recommends that there should be no routine pre-treatment if you are planning for an early invasive treatment for other reasons as well. It could be deleterious in a patient with aortic dissection, intracranial bleeding. It may increase the bleeding risk or delay the procedure if you are planning a CABG. The ESC also recommends prasugrel to be preferred over ticagrelol based on the ISAR React 5 trial, where the primary endpoint, bad outcome, was more with ticagrelol. There was a non-significant trend towards a higher rate of death, and the major bleeding was equal. But this is not accepted by most people. Still, it's a question mark. So you can use either ticagrelol or prasugrel. Prasugrel only after knowing the coronary anatomy. So if the patient comes, you do an angiogram, you load with aspirin, look at the coronary anatomy. If you are going to do a PCI, use prasugrel or ticagrelol. If you are not sure, you are not going to do the angiogram, when load him with ticagrelol. What about the role of clopidogrel? Today's era, it has got a limited role, and the recommendation is that use it only when these two drugs are not available, cannot be tolerated, or are contraindicated, especially if the patient is going for an invasive management. All of us know the loading dose as well as the maintenance dose. These were the two trials that made clopidogrel inferior to the other two drugs, the tritontim E38 as well as the Plato, where clopidogrel fared less than prasugrel as well as the ticagrelol. So there is some controversy regarding the pre-treatment part, but the current practice, most of places I think, is load with aspirin plus clopidogrel, and if it is an invasive management, aspirin plus ticagrelol. The next area is how long to give this dual antiplatelet therapy. The consensus is 1 year. It can be extended or it can be modified. Whether you extend or modify it is decided by the ischemic risk of the person as well as the bleeding risk of the person. This is again from the European guidelines. When a patient comes with a non-ST elevation ACS, as we already said, we have started him on a dual antiplatelet, aspirin plus prasugrel or aspirin plus ticagrelol or clopidogrel, whatever be the combination, you give it up to 12 months if the patient has got a high ischemic risk. After 12 months, in selected groups, you may continue that. I'll come to which selected groups, or you may change it to what is known as DAT, dual antithrombotic therapy, where you use an anticoagulant instead of a second antiplatelet agent. So extending DAT or changing to DAT, how do you decide? Again, this is based on various factors. If the patient has got a complex CAD, along with one of the following, like diabetes, history of recurrent MI, multivessel CAD, coronary artery disease with peripheral vascular disease, premature, less than 45 years, accelerated, person coming back again within 2 years, concomitant systemic inflammatory disease. These are people where you may extend the DAPT or try to change it to DAT. Technical aspects of the intervention, if it is done, if you are placing 3 stents or more, 3 lesions or more, total stent length of 60 millimeters, very complex procedure like a left main bifurcation stenting, total occlusion stenting, or the last patent vessel, or if the patient develops stent thrombosis on antiplatelet treatment, again, we may continue the dual antiplatelets or change to DAT. So what is this DAT? Dual antithrombotic treatment, where we use a low dose rivaroxaban or a low dose of the other NOACs. Rivaroxaban is the most widely studied, so that is why I chose that along with an antiplatelet agent. The dose is 2.5 milligram BD. The second part of the dual antiplatelet therapy is modifying that. Modification may be in the 4 varieties I have shown there. You may de-escalate it. That is, you change from a potent P2Y12 inhibitor like ticagrelol to clopidogrel. You may shorten the duration of dual antiplatelet. You may skip the aspirin, or you may shorten the duration of aspirin. These are the various trials that have looked at these 4 modifications. So coming back to our recommendation, if the patient has got a low ischemic risk, after 3 months, the ESC is recommending that you skip aspirin. You continue ticagrelol alone. If the patient, on the other hand, has a high bleeding risk, aspirin plus clopidogrel is given for the first 3 months, then you continue aspirin alone. Skip the clopidogrel. If he has a very high bleeding risk, aspirin with clopidogrel for 1 month and then clopidogrel alone. So only 1 month dual antiplatelet therapy is recommended. How do you calculate this risk? There are various risk scoring models, the BARC model, the DAPT score model, so many models. I am not going to that. The next area of problem is triple therapy, where aspirin, P2Y12 inhibitor, plus an oral anticoagulant has to be used as a must in a patient with concomitant atrial fibrillation or a concomitant venous thromboembolism. We have to use an oral anticoagulant. Then what will you do? Which oral anticoagulant? Will you choose warfarin or one of the non-vitamin K antagonists? There are certain group of patients who are not eligible for NOACs. You have to use warfarin in them. If the person has an LV thrombus, mechanical prosthetic valve, moderate or severe mitral stenosis, we will have to give warfarin along with DAPT. Otherwise, the recommendation is to use NOAC in a patient with AF plus ACS plus PCI. These are the various trials, the OST, Pioneer, Redual, PCI, Augustus and Entrust, which have all shown that double therapy, the bleeding risk is less than triple therapy. So the default strategy is start the triple therapy, NOAC plus clopidogrel plus aspirin. At 1 month, you change to NOAC to clopidogrel, and at 1 year, continue the oral anticoagulation alone. If there is a high bleeding risk, even within 1 week and 6 months, you can reduce. If there is a high ischemic risk, we can use ticagrelol along with NOAC and aspirin. After 1 week, skip the aspirin, and after 6 months, change to clopidogrel, and at 1 year, come back to NOAC. So again, the problem is none of us stop the antiplatelet after 1 year. If the person has atrial fibrillation and a stent gone in, we continue with both because we are afraid, is it safe to stop? Actually, it is unsafe to continue both after 1 year. As per the AFFAIR trial, which was published in NEJM in 2019, where they shown that using oral anticoagulation beyond 1 year created more problems than saving the patient. So what is the dosing in triple therapy? We have to use the standard dose, 20 milligram rivaroxaban or 15 milligram if there is a high bleeding risk. Probably I have confused you, because I was going a little fast because of the shortage of time. What is the future for us? People are moving to factor 11 inhibition instead of factor 10 inhibition. What does that mean? When there is a break in the endothelium, there is a clot. That is important for hemostasis, for your protection. It can also lead to a pathological clot. Actually, we want to prevent the pathological thrombus only, not the physiological one. By inhibiting the factor 10, we are inhibiting both. So, your pathological clot is gone, but your hemostasis is also gone. You tend to have more bleeding events. On the other hand, if you inhibit factor 11, your physiological clot will remain and the pathological clot will go away. There have been trials, at least 3 or 4 trials have been published with factor 11 inhibition, and people are moving on to that direction. So to sum up, this is a new area or a rather controversial area of antithrombotics in CAD. We have to carefully weigh the bleeding risk of the person. This is very important. Previously, we were thinking only of the ischemic risk. Load them with double antiplatelets. But we have to think of the bleeding risk. Lot of new data and new drugs are coming in and likely to be incorporated into the new guidelines soon. Till then, we will have to individualize the treatment with judicious decisions. We will have to see each patient, his risk factors, and go back to the charts and see what is the best for him. Thank you for the patient listening.
Thank you, sir. That was a really great talk in a short time period. You have completely encountered everything regarding the antiplatelets and the antithrombotics. So, 2-3 areas that, sir, I think you have not touched. Only might be everybody will be knowing. Non-cardiac surgery. What is your consensus regarding patient going for a non-cardiac surgery? How and when to stop antiplatelets and antithrombotics?
After sorry for the bad voice. After an intervention.
After the intervention.
See, one thing, we should see whether the surgery is an emergency one or a non-emergency one. Non-emergency one can be postponed. Suppose it's a post-myocardial infarction, postpone it. Emergency one, we cannot do anything. We'll have to go for the surgery.
And what about nowadays NOACs are very commonly being used. So in the same manner as warfarin, we have to stop the drugs and
No, we can stop them with, 1 day prior to the surgery. They have a very short half-life, unlike warfarin.
Kannada's, it was fantastic as it has always been. 2-3 things. One is there any data for the use of prasugrel for a longer period of time after the usual specified period of 6 months to 1 year of dual antiplatelet therapy?
No.
Second, what is our current role of cangrelor in the antiplatelet therapy scenario?
Yeah, I did not touch upon cangrelor because we don't have
It
that
is available right now. We
No.
started using it.
Yeah. But not very commonly available. That's why I did not touch upon that.
And why the data is in favor of prasugrel for the use in acute coronary syndrome. But the intake of prasugrel in India is too low.
Yeah.
What do you think the answer is? Why is it like? Because prasugrel, now the original brand of prasugrel is out of India. We don't have it. The prasugrel is cost effective also. The cost of prasugrel is much less than the ticagrelor. Why we are not taking up the prasugrel? Is it because of the fear of the previous bleeding episodes which was highlighted because that black box warning and all?
Maybe because of that, or maybe we are continuing with the preloading. Because you can give prasugrel only after you know the coronary anatomy. Ticagrelor you can give. So that's why maybe. Second thing, people are afraid of prasugrel because of the warning that came initially. But now they say that you can reduce the dose of prasugrel.
Yeah,
Even in the high risk group, you can
The
use
5
it.
milligram you can use
Yeah,
the
with
5
5
milligram.
milligram you can use.
And,
Actually, it's more cost effective.
And in your algorithm, when you use a dual pathway inhibitor, that is, you are inhibiting the platelet and the thrombotic pathway, you are using clopidogrel rather than aspirin. Is it out of a recommendation? Because most of the studies were done with actually aspirin. Is it because of the fear of GI bleed?
Yeah, fear of
GI, that is, I think practically that's very important because aspirin increases GI bleed, rivaroxaban increases GI bleed, dabigatran increases GI bleed. So when a NOAC is combined, I too prefer to combine with clopidogrel rather than with aspirin. Is aspirin on the way out?
Not in the acute phase. That's why I initially said, when we start in an acute coronary syndrome, aspirin is definitely beneficial. But in the chronic phase, probably aspirin is coming down.
Because in the Augustus trial also, they used it only in the first 6 days.
Yeah.
Afterwards, what I perceived is that aspirin is not an effective agent in combating with the stent thrombosis. That may be the reason why after 1 month or so, aspirin may not be that effective. At the same time, it can be counterproductive. And all the shorter DAPT regime is taking away the aspirin.
Yeah.
That's why people thinks that the aspirin may be on the way out. But it has to stay for the initial period of the acute coronary syndrome. And there is no role for dual antiplatelet therapy in the chronic coronary syndrome, except for the shorter duration, 3 months of therapy. It is 3 to 6 months of therapy following an intervention.
Yeah.
They are much fit for the dual pathway inhibition. Polyvascular disease, diabetic patients, peripheral vascular disease with coronary artery disease, renal dysfunction, and younger patients where the bleeding tendency can be less. In the dual pathway inhibition, after 1 year, actually the bleeding tendency comes down. The benefit comes because it prevents the ischemic episodes. For Indian population, maybe a better population rather than the Western population for a dual pathway inhibition.
See, if you look at the indications, as Jabir said, a person with diabetes, less than 45 years of age and all, is much more common with our population. So that is definitely a good indication.
Sir, you wanted to make a comment?
The combined CAD and CBA, what is your
The regular recommendations are dual antiplatelets in the initial period and stop after 1 year. The problem is if such a patient is going for a stenting, what to do, whether we continue or not.
Just wanted to ask, if the patient is not loaded with clopidogrel, then you do an angiogram, and then after how many hours of loading you can do the plastic procedure? Say,
So
for
if
example,
the pre-treatment,
the clopidogrel takes longer time
definitely,
compared
sir.
to other two drugs.
No,
So
if you are going for
planning to give only clopidogrel, and you have not loaded the patient, the angiogram showed a setup where angioplasty is required. What should be the duration of loading and the plasty procedure?
Sir, I think if you are planning to use clopidogrel during your procedure in an acute coronary syndrome, preloading is the best. The other one, deferring the preloading until you see the coronary anatomy, then you have to use either ticagrelol or prasugrel because they start acting within 30 minutes. Then you cannot use clopidogrel at all because you'll have to wait for such a long time in an ACS patient.
You have to wait at least 4 to 6
Yeah.
hours before
cannot wait that much
it
time.
becomes effective.
Because all the trials with clopidogrel have shown that it has to be preloaded.
Just one more comment. See, there has been a South Korean study which has shown that combining silostazole is found to be extremely beneficial. It has got two benefits. One, it reduces, actually it is an endothelial function improvement drug which actually reduces the risk of bleeding even though it's a third antiplatelet drug. And also the studies have shown that on long-term basis, the restenosis rate also is much less on patients who received silostazole for 6 weeks to 8 weeks. Can I have your comments, please?
Sir, I have come across this study, but no large-scale studies or no recommendations have come on
That
it.
was restricted to a South Korean study.
Small
But
population.
I continued to use it and I found that
And sir, the scenario you described, a patient who was not preloaded, ACS, angiography show critical lesions with thrombotic burden, that may be a situation where you can start the patient on cangrelor, do the procedure, because when you use clopidogrel in cangrelor patients, you have to load the patient up once the cangrelor is over. Otherwise, there won't be clopidogrel in the circulation when the cangrelor's effect has come down. Or you can load with ticagrelor, use cangrelor, do the procedure. In other situations where this IV agent can be used is patients who cannot take an oral drug, who are intubated, who are in shock, who are given morphine. So that may be the new drug that has come into the arena. It's not a new drug, it's an old drug which is re-emerged.
it was not being put into practice.
Yes,
Now
sir.
it is coming up in a big way.
Yes, sir. Thank you, Karanadas.
Okay.